In the beginning, I'm not sure we really thought there was a problem. So Dave just went to a urologist. It wasn't an infertility specialist. And because, you know, after a while, nothing was changing and he wasn't getting any better. And, you know, we were just getting frustrated. It's like, well, what are we supposed to be doing? What are we supposed to be asking this doctor? What should he be telling us? And what I did is I stepped in and started going with him to the doctor because I was just very frustrated at that point. And that's when he had, you know, he says, well, you know, I'm not really sure what to tell you. I think it was at one point. And I'm like, my God, you know, this is a big help. So he had said, well, I do have a specialist I can recommend you. And I guess it was naive on my part not to really think, well, geez, I figured you're a specialist too, not realizing that there are infertility specialists in urology.
One of the key things that Kathy and I experienced through all of this is that as we found out, as we learned more and more about the subject matter, we trained ourselves and we researched the issues and we investigated all the possibilities as we went along to make sure that we had enough knowledge to contribute to some of the decisions that were going on. Well, we found out that there's a lot of misinformation out there, and couples are going to be struggling to find out what tests they should have and what procedures they should have next. And the two things that helped us, we had a great physician working with us, and we also did the research and were willing to take each step as it came along, and then if that particular test or procedure didn't work, we'd move to the next one, and we kept moving forward until we got the results that we wanted.
You should always go with your questions, and what I found is the specialist we work with was always willing to sit there and answer all of the questions. No question was stupid. If you have a question, you should ask it. You never know. I mean, it might help you, but always go prepared and don't expect to remember what you wanted to ask. Put it down in writing, because when you get there, you could be a little emotional. You never know. So it's better, I mean, you can give them a copy of it and have them read it and discuss it with you.
Infertility, the inability to conceive a child within 1 year of unprotected intercourse, or the inability to bring a pregnancy to term, is presently affecting approximately 15% of the population. You are not alone. Ours is a generation who seeks to live life to the fullest. Many of our goals and aspirations circle around one day having a family. When it becomes apparent that starting a family may not be as easy as we expected, often it is assumed the problem lies with the female partner, and generally it's the woman who seeks help first. We now know 50% of infertile couples have what is called a male factor problem. This video explores this often misunderstood and complex area. Males tend to overlook the possibility of a male factor problem when it appears they function properly during intercourse. In fact, 20% of these infertile couples actually have complications involving both partners. Therefore, if you fit the category of what the medical community views as being infertile, the situation must be viewed as a couple's problem. In many cases, the solution may not be as complex as first thought. The problem could be as simple as improper timing.
Because the greatest chance for pregnancy to occur with even natural intercourse is during the exact time of ovulation, many couples do not understand that the appropriate timing for intercourse would be once every other day in proximity to the time of ovulation.
We did that for about a year.
Yeah, but we never really kept track.
No.
So in my mind, I think that there were several cycles where there wouldn't have been, we weren't anywhere close to the ovulation point.
The woman will keep track of her ovulation cycles using a technique called basal body temperature monitoring. During the course of this monitoring, the woman then notes temperature changes which are associated with the ovulation event, typically at day 14 on the 28-day cycle, which is a median cycle length for most women.
Because a lot of times, with both of us working, it gets to be a real drag trying to force the issue, because you know it's like tonight's tonight, and you happen to work 10 hours and she works 12 hours, and it's like, do we have to do it tonight? Well, if we want a chance, you do. Or it's like, we'll say, well, we'll do it tomorrow, because that'll be close enough, and you may have missed the window without realizing it.
Although the basal body temperature charting of the woman will often help to indicate if she is ovulating normally, even in some normally ovulating women, the basal body temperature charting can be inaccurate. In such cases, or in cases where accurate timing of intrauterine insemination is required, the woman may monitor herself with a test kit of her urine which indicates the hormonal surge associated with ovulation. At the time of ovulation, the level of luteinizing hormone in the woman's system, or LH as it's referred, will increase approximately 24 hours prior to the actual event of ovulation. As a woman is monitoring for ovulation, she can use an enzymatic test kit with a dipstick in which she collects a small amount of urine in a cup and looks for either a blue or pink color change on the dipstick associated with the high hormone levels in the urine at the time of ovulation.
You're almost, you're almost second guessing it when you know it's that pink. I remember bringing it into Chip and at 6 o'clock in the morning saying, "Does this look as pink as it does on the box?"
And I had like one eye open and one eye closed.
It's almost like you don't want to gamble, because if you don't pick that
optimum day,
then you lose it for the next month. And it was just, you just weren't sure. You're always second guessing yourself.
Some people think that having the greater frequency of intercourse, possibly as many times as often at the time of ovulation, is the best way. However, we have found that this really depletes the number of sperm present in the female reproductive tract during the time of ovulation, and often go back and correct such couples who have been misinformed about the appropriate frequency of intercourse.
When it becomes apparent that a pregnancy is still not being conceived, the couple should seek the advice of a reputable physician that specializes in infertility. During the initial consultation, the physician should ask history questions that pertain to the male.
One of the things that's very important in talking to a couple is to find out if they use any lubricants when they have sexual intercourse to make sexual intercourse more comfortable. Unfortunately, the vast majority of lubricants that are sold over the counter actually are spermicidal, meaning that they actually will kill sperm. There are really very few lubricants that can be utilized that will actually not interfere with sperm production. One of those actually turns out to be peanut oil. Another one, strangely enough, is egg white. So you have to be very careful to make sure that the couple's not using some form of lubricant that's actually killing the sperm.
When one considers the fact that the testicles are normally housed in the scrotum, which is a few degrees cooler than the body temperature, if one goes into a hot tub for 15 minutes a day, 7 days a week, at a temperature greater than body temperature, we can note how there is an increased heat which can be damaging to sperm formation. So even some of the less obvious lifestyle issues may also be an issue in complete assessment of fertility status.
Certainly in the case of the male, another thing that might be important in their history is the type of underwear they wear.
I can't tell you how many times I had people at work and stuff like that say, oh, well, you know, try wearing boxer shorts and this and that.
Underwear that aren't tight, that allow more freedom for the testicles, will promote better sperm production because they don't interfere with the temperature of the testicle as would tighter underwear or tight-fitting pants.
I mean, you could bump into somebody on the street and who may have heard something about it, and they suggest, oh, well, wear bigger boxer shorts, and that'll help, you know. So all of a sudden you go home, and you go out to the store and you buy, you know, I buy size 40 boxer shorts, you know, and I got to wear suspenders to hold them up.
Certain lifestyle factors as they apply to male fertility, such as stress, alcohol intake, recreational drugs such as marijuana, and even cigarette smoking, are difficult to quantitate with an exact effect upon male fertility. However, there are several studies now in the literature to implicate amongst those cigarette smoking as being one of the greatest potential factors.
We don't have any experience with recreational drugs. We're both pretty much in good shape. We do get a fair amount of exercise. No smoking. Used to have limited alcohol consumption. We're down to almost zero alcohol consumption.
Yeah, so.
Which further is more frustrating because we are in such good shape. There's no real explanation for the impaired infertility.
Another concern is the potential work hazards, and the potential work hazards we're concerned about would be exposure to various chemicals and exposure to radiation.
I used to be a chemistry technician in a nuclear power plant, so I have had some minor radiation exposure. I have worked with some chemicals, not to any great extent to where it would, that I feel that it's caused any problems.
In general, radiation really doesn't cause a problem for sperm production, with the exception with those individuals who are having therapeutic treatments with radiation. In other words, those individuals who unfortunately have some form of cancer, be it testicular cancer or something that will require them to have therapeutic doses of radiation or X-ray treatment. And that certainly can result in loss of sperm production.
In addition, certain occupational exposures, such as chemical pesticides, radiation, or heat, are again difficult to quantitate. However, if we can eliminate these factors and then see a significant improvement in sperm quality on the semen analysis after 3 months, then we know that in this individual case, these factors have been of significance.
Another thing in the history that would be very important would be any history of past infections that the male might have happened. One of the things that concerns us the most is the history of a mumps infection in an adult. Mumps infections in general in young children, which is when mumps usually occurs, usually don't result in infertility, but in individuals who are older, those individuals who've gone through adolescence, who encounter the mumps virus and actually end up with a mumps infection, those individuals can be at risk for developing a problem with fertility and an inability to produce sperm.
It is also important to be aware of recent viral infections which may have impacted upon the man's current sperm analysis, so that in the history, any semen analyses obtained within 8 weeks of a febrile viral illness should be repeated so that we can be sure that this isn't just a temporary effect of the viral illness.
Other infectious agents can also lead to infertility, and those agents that we're concerned about are gonorrhea and chlamydia. Both of those organisms are commonly found organisms that are sexually transmitted. So unfortunately, in individuals who have more than one sexual partner, or perhaps may have multiple sexual partners, they may have actually encountered either the gonorrhea bacteria or the chlamydia bacteria. And we have instances of individuals who've come to us who actually have had scarring and actually have had a blockage of the epididymis because of an infection with one of those bacteria.
We went through all the history of my medical history that I had, and I think just from the test that he performed in the office at the time, he felt that the diagnosis of epididymitis was correct, and also that the epididymitis was most probably creating a blockage, which was the reason that there was no sperm there. But he wouldn't be able to determine that unless surgery was performed. So at that time, he suggested that the first tactic that we would take is to try to cure the epididymitis without surgery, which would mean I would go on a stronger form of antibiotic, which I did take for about 4 months to see if that would alleviate the problem. And after 4 months of being on that very strong antibiotic, there was still really no change to the condition, and there was still no sperm. So at that point, the only solution was to have surgery to find out exactly what the problems were and to correct it if possible. I have 2 children from a prior marriage. My daughter is now 15 and my son is 13. And we really didn't, in my first marriage, I didn't have any problems with my sperm count or creating a pregnancy. So this has arisen all within the last 3, 4, 5 years.
Another thing that's important in the history to elicit is any past surgical history.
Such items as repair of an undescended testicle before or after puberty can be crucial to interpretation of an individual's fertility status. Other surgical procedures or medical diagnoses, such as pelvic surgery or a history of diabetes, may be associated with problems in ejaculating in a forward manner. When this occurs and someone ejaculates in a backward manner into the bladder, this is called retrograde ejaculation. Retrograde ejaculation can sometimes be corrected with medication, and when it is not correctable with medication, the sperm can be retrieved from the bladder with medical assistance and used in insemination cycles of the wife.
When an individual undergoes a hernia repair, it's possible that duct can actually be ligated or clipped or injured during the process of a hernia repair, and subsequently can result in an obstruction and a decreased sperm count. So certainly when someone comes to us with infertility and a low sperm count, one of the things we'd want to know would be, have they had hernia repairs?
During the initial consultation, following the gathering of the historical perspective, a physical exam of the male must be performed.
On the physical exam, we are assessing for any anatomic abnormalities which may be associated with fertility problems and then may potentially be specific correctable causes.
The physician may discover on examination is an absence of the structure that leads from the testicle to the penis. In other words, the vas deferens, which is one of the tubular structures that goes from the testicle to the penis, may actually be lacking. And certainly if that's the case, there's no way for sperm to get from the testicle to the outside world.
However, with modern technology, we are able to harvest sperm from what is present of the male reproductive tract, and then take these sperm and immediately mix them with the wives' eggs using the in vitro fertilization process, and in up to 15% of initial attempts we are able to achieve a pregnancy in someone who would otherwise be totally unable to achieve a pregnancy without medical assistance.
Another problem that the examining physician may encounter is an undescended testicle, or perhaps 2 undescended testicles. Certainly testicles that fail to descend, that remain high in the scrotum or actually may remain in the abdomen, are associated with decreased sperm production. And again, it may be because of the fact of a failure for the testicle to obtain a temperature that's somewhat lower than the body's core temperature.
In a man who has a very low sperm count, who also has very small testicles, we have evidence that there may be an underlying problem with the hormones the man is producing in a too low of a level to stimulate appropriate testicular growth, or on the other hand, if the hormone levels are very high, then the man may have acquired this testicular damage, which cannot be corrected with hormone treatment.
In the physical examination, the urologist may elicit a varicocele. Again, a varicocele is a dilated vein around the testicle.
In fact, varicocele is a normal finding in up to 15% of men in the adult population. However, the incidence of these varicose veins around the testicle in the infertile population may be as high as 40 to 50%. The primary theory by which varicocele affects a man's fertility is based on the concept that with the increased pooling of blood in these varicose veins around the testicle, there is also an increased heat level. This has been documented by some scientific studies in the past. We know that heat is definitely damaging to the testicle's ability to form sperm. We further suspect that it is also having an effect upon the maturation process of the sperm in the epididymis, so that we can see any one of a number of defects in the semen analysis caused by a varicocele.
Following the physical exam, the next step is an evaluation of the man's semen.
One of the things that we'll frequently find when we obtain a semen sample is that the count's normal, but all the sperm are dead. The first thing that we have to think of is, was there some problem in sperm transport? Obviously, the sperm have a limited lifespan when they're sitting in a container. And in the majority of instances, we would like to receive a sample within 45 minutes to an hour maximum from the time it's actually produced.
The one that I did in Stratford was really bizarre. The doctor was in a clinic which was in Stratford, and basically, you know, you just showed up, gave him your semen analysis, where you told him what was going on, and he was going to do the analysis right there, and didn't provide any particular literature of any type or anything to help the process along. So I remember sitting in a parking lot outside of a supermarket, or in a discrete. Let me make this clear. It was a discrete parking area in a shopping center. Yeah, and essentially having relations with myself to the point where I was able to get a semen analysis, or a semen sample, which was very strange. And I kept looking around, wondering if like somebody wasn't noticing me. And then subsequently brought it over to the doctor's, which was just down the street, and he did his check.
The important point is, though, when one of the first things that we need to think of when we see a bad sample, i.e. a sample with low motility, was there a problem in transport? Did it not get here in time? Was it cold outside, and was the sample left out in the cold and not at body temperature, which would have allowed for the sperm to die?
Anyway, so when I went to Boston and I had to do the semen analysis, this impressed the heck out of me. These guys were big league. They not only gave me the little cup for the analysis, but they provided me with a videotape. And they had a little machine in there, and I just went in and plugged it in and had entertainment and was able to accomplish the sample without too much difficulty. That was very strange. And of course, then you come out and you hand the secretary back the tape, and you know she's like smiling at you, and I'm smiling at her. You know, I mean, everybody knows what's going on, and it's very awkward feeling.
During the semen evaluation, there are 5 basic criteria that the technician is looking at. 1 is volume of ejaculate. 2 is the number of sperm, or count. 3 is motility, or moving forms. 4 is morphology, or the shapes of the sperm. And 5 is forward progression.
Classically, a normal semen sample will have a volume somewhere in the neighborhood of 2 to 5 milliliters total volume. Interestingly enough, individuals who have much larger volumes may in fact have some difficulties with infertility. They may actually have a much larger volume of semen, which is the liquid portion of the sample, which may actually decrease the actual concentration of the sperm per cc or per ml of the sample itself. And this large volume may actually be associated with some impairment in fertility. In addition to the volume, other things that we're obviously concerned about are the count. In general, we would like to see an individual have a count that's above 20 million sperm per milliliter. In addition to the count, we're very much interested in motility and morphology. In other words, what percentage of those sperm are actively moving and what percentage of those sperm have a normal appearance. And in general, we want there to be greater than 40% of the sperm being actively motile and greater than 40% of the sperm having a normal morphology. When we talk about normal morphology, what we're talking about are those sperm that fit very strict criteria in terms of the appearance of the head of the sperm, the neck region of the sperm, and the tail piece of the sperm. There are a lot of abnormalities that we can see that can lead to a decreased percentage of the sperm having a normal morphology. Some sperm may actually have a very, very round head as opposed to a more cylindrical type configuration of the head, and that may be associated with impaired sperm function. Some individuals may actually have double-headed sperm, and that may interfere with sperm function. Individuals may actually have defects in the tail. They may have an abnormality in the tail piece. So there are various aspects of the morphology that we're interested in looking at. Another thing that we'll look for in the semen analysis is, again, evidence of infection. If we see cells that look like cells associated with infection, we may then suggest that the patient have a special study done with a semen sample that can actually identify as to whether or not those cells are white blood cells, which would suggest to us that this individual may, in fact, have an infection. Obviously, of concern is on the routine sperm analysis when we see absolutely no sperm whatsoever.
You know, the assumption, and I think most guys would, or most people would probably have the assumption that if there's an ejaculate, you assume that there's sperm coming out. And it was only after having, gone through the analysis a few times that I came to understand that there was maybe, I don't know, maybe 10% of the ejaculate or something like that is actually sperm, and the rest is just fluid. When I was getting the fluid fine, I just wasn't getting any sperm.
In individuals in whom there is no sperm production whatsoever, it's incumbent upon the physician to then try and determine why that individual has no sperm production. And again, there are several reasons that this may happen. The two most common would be, one, an obstruction of the outflow tract from the testicle to the outside world, or two, a failure at the level of the testicle to produce sperm.
A major factor in proper infertility evaluation is the evaluation of various endocrine or hormone levels in the blood. The four primary hormone levels evaluated are FSH, or follicle-stimulating hormone, produced by the pituitary in the brain; LH, or luteinizing hormone, also produced by the pituitary; testosterone, produced in the Leydig cells within the testicles; and prolactin, also produced by the pituitary. These hormones have a direct relationship to sperm quality and quantity.
The male reproductive system is a very, very integrated system, and it actually requires function at the level of the brain as well as at the testicle. There are two hormones that actually drive the testicle that are manufactured by the pituitary gland in the base of the brain. Those two hormones are called LH and FSH. If an individual has some impairment in the production of those hormones from the pituitary gland or in the release of those hormones from the pituitary gland, the testicle doesn't receive the message which drives it, and therefore it may not produce sperm or the male hormone called testosterone.
And in this case, what is called hypogonadism may be treated with giving the man hormones that are not normally present in his body, so that a man receiving replacement LH and FSH may then produce normal amounts of sperm and may then be able to impregnate his wife.
The individual may also have an isolated defect within the testicle. In other words, the release and production of LH and FSH from the pituitary gland may be fine, but the testicle is incapable of responding to this message and doesn't produce adequate amounts of testosterone, which are required for sperm production.
The levels of FSH and LH released by the pituitary are controlled by a feedback mechanism regulated by testosterone and estrogen. Estrogen is typically the major female hormone. However, small amounts of estrogen are also produced in the man's body as testosterone is broken down. The higher the level of testosterone, the more testosterone is broken down to estrogen, and thereby the testosterone and estrogen will act on the pituitary in what is called a feedback loop, so that the higher the estrogen and testosterone levels, the less of FSH and LH will be put out by the pituitary gland.
There's another hormone that's produced by the pituitary gland that's called prolactin, and it's been demonstrated that in some individuals, elevated levels of prolactin may lead to problems in fertility. One of the problems certainly that high levels of prolactin can lead to are impotence or problems maintaining an erection. But there's also some evidence, although it's not 100% clear, but there is some evidence that high levels of prolactin may interfere with sperm production. So in addition to LH and FSH and testosterone, another hormone that we would like to check would be the hormone that's called prolactin.
In 1/4 to 1/3 of the men who present for fertility evaluation, there may be no obvious reason for the low sperm count, low percent of sperm movement, and or low percent of normal appearing sperm. In these cases, the diagnosis is called idiopathic male infertility, which means that we have not been able to discern the exact cause. In such cases, the hormone levels are very often normal, and we may be able to get enhanced sperm production in up to 1/4 of these individuals by giving them additional hormone treatments, such as with the oral medication clomiphene or with injections of LH or LH analogs.
Finally, an evaluation of the urine should be made.
One of the other things that will be done as part of an initial examination of the male will be assessment of any evidence of infection. And one way we can look for infection is by obtaining a urine sample from the male. In other words, obtain a urine sample and see if there's increased numbers of bacteria or white blood cells, what might suggest to us that this individual has an infection. And if that's the case, we might then want to go ahead and culture the urine to find out what the specific organism is and then treat it, because infections themselves, as I've stated, may lead to scarring and damage that may interfere with sperm production. So looking for an infection is an important thing. Another thing that we frequently look for is the presence of sperm actually within the urine sample. There are those individuals, although relatively rare, who may have a condition that's referred to as retrograde ejaculation. That's a process whereby when the individual ejaculates, where some of the specimen, or maybe even all of the sperm specimen, instead of coming out of the penis, actually goes into the bladder.
This evaluation is often expanded then to include evaluation of a post-ejaculate urine. In other words, once the man has had intercourse, he urinates and the urine specimen is evaluated for sperm. If there is no sperm, we have ruled out retrograde ejaculation. If, however, sperm are present, then further attempts can be made to assess numbers of moving sperm and whether it may be reasonable to consider harvesting sperm from the retrograde ejaculate to then be used in insemination cycles. In spite of having a normal semen analysis, a normal physical exam, and no finding of a reason for female infertility when the wife has been evaluated, a couple who then falls into this category of seemingly unexplained infertility can be assessed further with special sperm testing, such as is performed in the sperm penetration assay.
What happened is Dave, at that point, the doctor also recommended a full workup on the sperm, a very, very detailed test, and the results of that came back and showed that even though his counts were normal, they really, the sperm didn't have enough penetration factor to achieve pregnancy on our own.
When the sperm binds to the egg, to get through all the surrounding layers of the egg, there are certain factors or enzymes that are released that actually help digest some of the layers surrounding the egg and help the sperm get into the egg. It's thought that the acrosome is responsible for the release of these enzymes. There are some individuals with these round-shaped sperm who actually lack an acrosome and therefore lack these enzymes.
And what they try to do is they test the penetration power of the sperm against what I believe to be is hamster eggs, and by looking at the test, they can determine at a certain level how strong the sperm is in terms of its ability to penetrate the egg.
Interestingly enough, these are not defects that we're seeing with routine semen analysis, because the magnification with routine semen analysis isn't as high as is required to make this diagnosis.
This test assesses only the early courses of the fertilization process. These early processes it assesses are the penetration of the egg and what is called the decondensation of the sperm head.
Once we've completed the evaluation with the male, what we'll next want to do is to evaluate the interaction between the male and the female.
The postcoital test involves an assessment of the woman and man's reproductive compatibility after intercourse. Anywhere from 1 to several hours after intercourse, at the woman's time of ovulation, the gynecologist will take a small sample of mucus from the woman's cervix. This mucus sample is assessed for the adequacy of the woman's mucus, as well as the adequacy of sperm movement and moving sperm numbers in the mucus.
One of the interesting things about cervical mucus is that it will be most appropriate for the process of fertilization just prior to ovulation. During other times during the month, the cervical mucus will actually be quite thick and tenacious, and there may be some value to this. There's some evidence to suggest that thick, tenacious sperm may actually impede the passage of organisms that could cause infection up into the higher reproductive tract of the female, which could result in damage to the tubes, which could lead to infertility.
One of the reasons for an abnormal postcoital test may be that either the woman is not ovulating normally, that the woman has an infection of the cervix, or that the timing for predicting ovulation has been inaccurate. In such cases, an abnormal postcoital test, if the woman is failing to ovulate, can be treated with hormonal therapy. In other cases, infections can be treated with antibiotics, and in still other cases, proper timing of intercourse can be more accurately determined with the ovulation indicator kits, or in the most severe cases, with ultrasounds of the ovaries to predict follicular release.
If it is finally determined that surgery is required to correct a male factor infertility problem, then it is the couple who should weigh the odds and make the final decision to proceed.
Nearly all of the surgery involved with correcting or assessing male infertility is same-day or outpatient surgery. In fact, it can very often be performed under local anesthesia with small incisions. The most common procedure performed is correction of a varicocele or varicose veins around the testicle. The two most common approaches for this are under local anesthesia to make a small incision low in the groin, where these abnormal veins between the testicle and the abdomen are carefully isolated under surgical magnification and carefully ligated or tied off. In this way, flow in a backward manner through these abnormal veins is eliminated and only flow through the normal, smaller veins occurs. An alternative method, which has become increasingly popular, is to use the laparoscope, a scope through the navel or umbilicus, in order to access these veins as they travel from the abdomen into the groin region. The potential advantage of this procedure is that patients may have somewhat less discomfort and may advance to work a little bit faster than using the more traditional low groin approach. In the case of testicular failure, the serum FSH level is often very high when compared to normal. In the case of obstruction, the serum FSH level is within normal limits. The only way, however, to definitively tell whether we have obstruction or whether we have uncorrectable testicular failure is to proceed with testicular biopsy. In this outpatient procedure, which is performed with a small incision over the testicle in the scrotum under local anesthesia, a small piece of the testicular tissue is removed, processed for the pathologist, who then reviews microscopic slides. On his review of these slides, he can tell whether sperm are being formed in the normal amounts, which is consistent with obstruction, or whether there is no sperm formation or a maturation defect at a level before the level at which mature sperm are produced. The more common level of blockage in the male reproductive tract is at the level of the tail of the epididymis, or at the level of the vas deferens. In these cases, the level of blockage is more carefully and accurately obtained with a procedure called vasography. In this procedure, the vas deferens is exposed within the scrotum under anesthesia. A small nick is made in the vas deferens under microscopic control, and dye for both radiographic or blue dye for confirmation on catheterization of bladder urine can be used to confirm the patency or openness of the vas deferens from the scrotum all the way up through the level of the ejaculatory duct. At the same time, the epididymis can be squeezed to see if fluid from the testicular side of the vas deferens then comes forth through the vasotomy site. During this procedure, when performed correctly, this fluid should be noted and examined under the microscope for the presence or absence of sperm. Microsurgery is most commonly used to correct blockages of the male ductal system in cases of prior vasectomy or in cases of congenital or acquired blockages of the vas deferens and epididymis. Some of these acquired causes include damage of the vas deferens from prior hernia repair or damage to the epididymis from trauma or through sexually transmitted diseases. In such cases, under the microscope, these tiny transport tubules for the sperm can be bypassed beyond the level of the blockage. In such cases, the procedure may be termed an epididymovasostomy, in which case a microscopic bypass of the blockage from the epididymis to the vas deferens is performed, or if there is only a small segment of the vas deferens which has become obstructed, it is called a vasovasostomy.
The recuperation time from the operation wasn't really as bad as I thought it would be. I was out of work for about a week, and I was in discomfort only for a day or two. But there's no real pain associated with the aftermath of the operation. It's mostly just a little discomfort, and I would say within about 3 weeks, everything's pretty much back to normal, and you can resume normal activities. I would say to anyone who has to face any type of operation at all, it's not really real difficult or painful, and you'll probably recuperate fairly quickly and be back to normal activities within a short amount of time. I think the philosophy basically is not to give up, to keep trying, and if A, B, and C don't work, try D, E, and F, and just keep trying things until you reach your goal.
Don't be embarrassed by a lot of the somewhat humiliating experiences you feel you have to go through. Don't let your ego get in the way. Try and be as patient as you can be, both with yourself and certainly with your spouse. Yeah, just kind of have faith. Just have faith.